Before we start our interactive session, and why I'm stressing on interactive session, because we have many doctors who are still in with us in this studio, and they might have a lot of questions. Farooq, Talha, do you have anything you want to add to your presentation from your presentations, or should we move to the interactive session?
Um, yeah, so I think there's a question which I can see in
Uh-huh.
group chat. So I'd like to answer that.
Sure.
That question is from Munir. There are few parts on that. So the one of that is like, should we keep an early intubation protocol or give patients trial of non-invasive ventilation? So I think I briefly touched that question earlier. So basically, this is a challenging question, to be honest. You don't want to delay intubation where patient acutely decompensates and you end up in a cold situation. So most of the physicians suggest early intubation, but then how you define early is not very clear as well. So this is variable from institute to institute. But I would think if you don't have any contraindications to try non-invasive ventilation, as Farooq described in detail, like if there's no risk of aspiration, vomiting, and then patient is not altered, in altered mental status, you don't really want to use non-invasive ventilation. In those cases, it's reasonable to try non-invasive ventilation in safe environment, since it can increase the risk of aerosolization as well. As long as you can closely monitor patients every 15 to 30 minutes, you can try non-invasive ventilation if there's contraindication, and just keep follow up, within 30 minutes, check technique, and they are, still having hypercapnia or, difficulties, then you can proceed to early intubation. Other thing is, as I said earlier in my slides, if some patients have conditions like COPD, heart failure, or AKI, those patients usually they can sometimes do well on non-invasive ventilation because that supports those conditions. So you can definitely give trial in those cases, as opposed to patients who have no real underlying conditions on those lines. Then you can also actually bypass non-invasive ventilation, especially if they are rapidly desaturating and their oxygenation is worsening really fast. Then you can bypass non-invasive ventilation step and directly intubate them. Other question Munir asked was, if we
I think
recommend.
should involve people who are here. We should involve them directly so
Yes.
that they can ask. Let me ask one question before we move to the interactive session. This question is to both to Farooq and Talha. It's a very basic question. When I was working in New York in ICUs in COVID crisis those days, so suddenly if a patient is ventilated, the oxygen saturation starts dropping. What are the 3 4 major steps which I should look while oxygen is dropping? Like how should I intervene in addition to PEEP and FiO2? What should be my algorithm quickly, because that's like a rapid response like situation. So I'm not an internist, I'm a general medicine resident, let's say, and I have this situation. What 3 4 steps should I look into to manage that hypoxemia on the vent? Yes, Farooq and Talha.
Yeah, I can start answering that question. Um, so if patient is hypoxemic on the vent, there are many things which can make patient hypoxemic. So I would start thinking about it as a as a circuit in series, right? So there can be problem with the vent. There can be, which is less likely, there can be problem with the delivery system, starting from tubing, endotracheal tube. There can be problem with the major airways like bronchoconstriction, aspiration of secretions, any obstruction. There can be problem at the alveolar level, like permeedema, pneumonia, pneumothorax, sudden PE, all of that. So I would start with things that can suddenly kill the patient and can suddenly and quickly be fixed. So you want to make sure these patients, many of these patients are on higher PEEP, they are agitated. Sometimes they can self-extubate themselves. Sometimes the ET tube is not, fully secured, and these patients can have like reverse regurgitations, and sometimes they can bite on the ET tube and cause that can cause obstruction. So you want to make sure, and sometimes they can have secretions. So first you want to make sure the patient is, the ET tube is connected. So look at the ET tube, look at the patient. The patient is not biting on the ET tube. Try to learn how to do suctioning from the ET tube. Make sure there is no problem with the suctioning, okay? So and then listen to the patient. If there's absent breath sounds on one side or not, think about pneumothorax. Then you want to look at the vent. And on the vent, you want to look at starting with peak pressure. Even before you look on the vent, look at the screen which is showing hypoxemia. Let's say if the patient's showing hypoxemia, you want to look at the waveform, how the pulse oximetry looks like. If it is a good waveform, then that is reliable. If the waveform is flat, that means that probably it may not be accurate, and especially if the patient looks comfortable. So you want to look at the screen, which is showing the pulse waveform, and then you want to look at the ventilator. And what you want to see on the ventilator, I would start looking first with the peak pressure. What is the peak pressure? The peak inspiratory pressure. The peak inspiratory pressure, if they're high, let's say more than 40, that's high. If they're less than 30 peak, I'm not talking about plateau pressure, I'm talking about peak inspiratory pressure, because for plateau pressure, you have to do end inspiratory hold, and the patient has to be compliant with the vent, breathing at the same rate as the vent. But peak inspiratory pressure are usually reliable, irrespective if the patient is breathing spontaneously. Now, they can be underestimated in patient, but they cannot be overestimated. So if the peak pressure is, let's say, more than 40, okay, more than 50, more than 50 is too high. So that would suggest that either there is an obstruction in the circuit, patient is biting on the ET tube, there is secretions, or the patient has bronchoconstriction like an asthma or COPD, or the patient has like pneumothorax, something like that. A patient has sudden pleural effusion. So you want to think about that. Some of these patients, when their ET tube, you want to look at the ET tube. When we put the ET tube in, there is protocol that you have to document what is the size of the ET tube and what level the ET tube is, let's say at lip or teeth. And that is usually documented by the nurses or respiratory therapist. And you want to look at the patient ET tube, or let's say at 21 at the teeth, and now it is 16 at the teeth. That probably the ET tube is out, and maybe in the throat. So you want to get a stat chest X-ray, make sure the ET tube is in, and if it is out, that patient may need reintubation. So those are the basics I would keep in mind while evaluating hypoxemic patients. You all are, how to manage pulmonary edema. If the patient needs a higher PV, in the end, when you come down, like let's say you come down to the point that you have ruled out these things which are non-ARDS related, and you think about this patient probably has worsening ARDS, then you want to go back to your ARDS-NETs table. You want to make sure patient is compliant with low tidal volume, patient needs higher PEEP, or patient needs higher FiO2, and you think about those things and adjust those things.
Thank you very much, Farooq. So let me paraphrase what you said, that whenever this thing happens, think of first the fixable problem, the conduction system, the circuit system, rather than the disease itself, and think of like the ET tube placement, secretion blocking the ET tube, obstruction, patient fighting with the vent, dysynchrony with the vent. These are very fixable problem immediately, and if you have no problem with these, then you can also play around the next step, as Aftab and Farooq mentioned, that you can play around with the PEEP and FiO2. Your target is, of course, in ARDS, you play around more with the PEEP, but still you tend to keep the plateau pressure. And the plateau pressure, as Farooq said, that to find a plateau pressure, you have to do a maneuver, and that maneuver is called inspiratory pause. And you cannot do that inspiratory pause if your patient is fighting with the vent. And you should not do very frequently inspiratory pause also, because every inspiratory pause actually increases the hypercapnia. So the plateau pressure is the difference between the, the plateau pressure should be less than 30, and the driving pressure is actually the difference between the plateau pressure and the peak pressure, and it should be less than 15.
Plateau pressure and PEEP, not the peak pressure, PEEP pressure. The pressure, the pressure which is set on the ventilator, PEEP,
peak expiration, peak. Okay, yeah. And then you have to keep that difference 15 or less. So these are the numbers you have to play around, and it's like
That's right. Sorry for interruption. Because we were talking about this plateau and peak pressure in ARDS, let me share a scenario really quick for 1 minute scenario that you see a patient on the ventilator, you see this pressure and what can you achieve? Then we can go back to the questions, okay?
Sure. Yeah. Let's do a practical application of whatever we learned, and then we'll involve our.
Yeah. Can you see my slide?
Yes, we can.
Okay. So you see here what I shared is that you have an ARDS patient who is ventilated, and the settings on the ventilator that you have the patient on is FiO2 100%. Tidal volume is 650 50 ml, which you calculate as 8 cc per kg ideal body weight. Respiratory rate is 18 and PEEP is 8. Okay. So you look at this and you look at the patient ventilated. The patient is fully sedated, and let's say the patient is drawing tidal volume of 650, which is set and not breathing above the vent. Let the patient breathing also 18 or 19, and then you do an inspiratory hold or inspiratory pause for, let's say, a second, and you see this patient plateau pressure is 35. You look at the saturation of the patient on the monitor, which is 90%. If you have, let's say, blood gas, which shows a saturation, a PO2 of, let's say, 53%. And then you calculate the driving pressure. You know, here you see the plateau pressure I already calculated is 35, and you have PEEP, which is 8. So 35 minus 8, the driving pressure is 25. So what do you do here? So this patient has many things wrong, right? Starting with, let's say, the tidal volume, which should be set as 6 cc per kg. And because the patient has a higher tidal volume, that's why patient has a higher plateau pressure. Your goal is of a plateau pressure of less than 30 and driving pressure of less than 15, maybe around 13, 12, something somewhere over there. And your saturation, PO2 saturation is like 90%. If you look at the trial from ArtsNet, they usually aim for PO2 of more than 55. This patient's PO2, I said, was like 53. So this patient is not saturating well. So what you want to do, you want to start with the tidal volume, and you want to decrease this patient tidal volume to 6 cc per kg, which is probably, let's say, 400. So you want to drop the tidal volume to 400, 420. And then the next thing you want to look at is the ArtsNet table. If you look at the table, which I may bring back here, this patient is on FiO2 of 100%, okay? And usually these patients with severe ARDS need a higher PEEP, you know, and this patient probably will need a higher PEEP. And you see the patient who has 100%, their PEEP minimal is set as like 22. So you want to increase the PEEP of these patients gradually. You don't want to go from 8 to 22 right away. What I probably will do, I will decrease the tidal volume, and I will increase the respiratory rate in order to deliver the minute ventilation. You know, I probably will increase it to from 18 to 24, and I will increase the PEEP to at least 14. And when you do that, you will see this patient's plateau pressure will probably drop to, let's say, 27, and driving pressure will drop to, when it is 27 and PEEP is 14, 27 minus 14, driving pressure will be 13. So this is, you know, this is what I will do. And then I will monitor this patient with a blood gas and the saturation, see how the patient is doing. And just remember, when the patients are on a higher PEEP, something we forgot to mention, let's say PEEP of 14, 16, those patients will need a daily chest x-ray to make sure their ET tube is not moving up because of the higher PEEP, sometimes because of the higher pressure which is being retained in the lungs at end expiration. That also the pressure sometimes drives the ET tube out. So you want to make sure every day, you know, you get a chest x-ray. Many times there's a limitation. We cannot get a chest x-ray, especially in Pakistan, because of the risk of exposure. If you cannot get a chest x-ray, that's fine. Many of the institutions here not getting chest x-ray in ARDS COVID patient every day, but you want to look at their ET tube, that whatever you mark the first day, the level on the teeth is still about the same. Okay. So I'll stop here, and I'll give it back to Waqas, and we can address more questions.
Thank you very much. That was very practical question. Farooq answered it very well, that whenever you have such situation and your settings are all here and there, so you have to follow a sequence. You do a low tidal volume, as Farooq said, 6 milliliter per kg ideal body, and then it will, of course, compromise the ventilation. So you go up on the respiratory rate to keep a better minute ventilation, and then you play around PEEP. And then your targets are driving pressure less than 15, plateau pressure, which is obtained after doing a maneuver called inspiratory pause, less than 30, and then all you are doing this to keep oxygen saturation above PaO2 on a blood gas above 60 or a saturation above 90. So this is how you play around, and there might be certain exception cases when you have to sacrifice one of these three factors, but you tend to play around these three factors, and then that's how you manage the ARDS. This is very basics, and as Farooq said, that when you have high PEEP, and we know the COVID ARDS require high PEEP, you have to keep an eye on the ET tube very often, because I have seen in New York a lot of self-extubations because all these ICU patients were being managed on the floors. Nurses were not very familiar with the sedation protocols. They were not enough sedated to RASS of -4, -5. And as a result of that, ET tubes were being displaced, patients were like agitated, and there were a lot of vent dysynchrony. We did not touch the sedation part in this session. We may do in next session when we are going to talk about the therapeutics in the COVID-19. But it is very important to keep patient very well sedated and keep central sedation. Don't paralyze the patient. They say that the number one cause of the GI bleed or stress ulcers in a ventilated patient is actually stress ulcer, which happens when patients are paralyzed but not sedated. Because they are awake, they know that they cannot move, and this causes enormous release of the catecholamines, and that a lot of time we come across the stress ulcers in the ventilated patient. So this is very important to keep them as sedated as possible, but at the same time you have to do these play around these three factors. So here we will stop, and we have a lot of participants. I would request everyone to turn on your video, and then if you have any question, the person who has question can unmute the mic and ask the question very briefly, and then we will take the answer from our panel. And I'm also keeping an eye on our Facebook comments. If you guys are listening us and you don't want to come in our studio, virtual studio, you can still type your question in a comment and we will try to answer. And then I would also persuade our participants here to share their concerns and experiences in ICU. Very briefly, what problems they are facing while managing ventilated patients of COVID. So Munib, you have question, Munib Jan? Because you were asking question in the chat box. Okay, I think you are mute. Anyone can ask question. Yes. Yes, Munib.
So, first of all, thank you very much. It's a very nice presentation. We learned a lot. The problem that we get here is, number one, patients on vent, patients with a central supply of oxygen, all of a sudden they start desaturating very quickly. And in spite of intubations, whatever we do, like within hours, they're gone. The procedure that the doctor said, we have tried all of them. We checked the intubation, we checked the ventilation, but nothing works. Another question, it was regarding the anticoagulation protocol. Here in both here in isolation wards as well as the ICUs, we are starting all the patients prophylactically on anticoagulation. So the question I want to ask, what do you think about this? Should we continue this protocol or modify this?
Okay, so you have two questions. One about the certain, in spite of following all the protocols after intubation, you think patient dies and hypoxia is not managed. And the second question is role of AC in COVID. Okay, so Farooq.
Yeah, I can take this question. So the patient who, despite doing all these things, who dies of sudden acute hypoxemic respiratory failure within hours, that patient probably is, we'll have to look at the patient whole data in order to comment, is probably too sick. If the patient has got all the care, that patient, and died within an hour or 2 hours of getting all the care, that patient probably got intubation later. That patient may have needed intubation way earlier in order for the standard therapy to work. Let's say if this patient needed intubation 24 hours earlier and we delayed that and patient was severely hypoxemic, and we're doing it as an emergent measure. You don't want to do it as like emergent measure, because that patient, even a relatively moderate hypoxemic patient, when we intubate the patient, what are the things that change? There are many things that change in that patient, right? One thing that changes is that we start that patient on sedation. When you start that patient on sedation, that can in itself cause hypotension. That is one thing that changes. The other thing that changes is that that patient who was breathing at a rate of, let's say, 35, or in many of these patients, they're breathing at a rate of 50. When we ventilate them, if we put the rate at, let's say, 12, what will happen? That patient will go into sudden acute respiratory failure with hypercarbia. And that in itself, the acidosis will lead to hypotension in addition to sedation. That patient initially was hypoxemic, now the patient will become hypotensive and patient will die. So what you want to do, like initially when you ventilate these, put these patients on mechanical ventilation, if they're breathing at very high rate, they need a higher minute ventilation. You don't think about low tidal volume initially for the first 2 hours. You want to start them at least about the same minute ventilation they were getting before they were intubated. So that's one of the common mistake. And what you want to do once you intubated them, initially you get them like 8 cc per kg for an hour or two, a high respiratory rate around 20, 22, and then you repeat their blood gas in 30 minutes. I bet you if you started them on low tidal volume, especially if you gave them paralytics during intubation, and then you started them on low tidal volume, they were getting a higher minute ventilation. Within 30 minutes, if you get a gas, their pH will be 712, 710, or even less than that because of acute respiratory failure with hypercarbia. So just remember that initially these first 1 or 2 hours until patient gets stabilized, they need a higher minute ventilation. That's one thing. The second thing is when you're starting these patients on sedation, initially what they have is they have a higher sympathetic tone. So they're compensating for, like, they have a high blood pressure. When you sedate them, you take away that sympathetic tone. They have a catecholamine depletion. And now their blood pressure will tank down. So just be ready that this patient will probably need a central line, this patient will need an arterial line to maintain the blood pressure. Just make sure this patient has enough IV access. So those are the basic things I would focus on stabilize, because these patients, putting them on the ventilator is probably the easiest thing to do. But once they get on the ventilator, the trouble comes. Then you probably will need to spend 2 to 3 hours on their bedside after putting them on the ventilator to stabilize those patients. So that's the answer for the first question. The second question was about anticoagulation. Yes, anticoagulation, I think initially there was some doubt that, well, is there really high risk, these patients high risk for VTE? But now I think everyone knows that this, and everyone agrees that these patients are very high risk for VTE. And they usually get VTE even if they're on the prophylactic dose of anticoagulation. Many of these patients usually need therapeutic anticoagulation, or 80% of the therapeutic dose, let's say 1 mg instead of, usually what you do, like you give like 0.5 mg per kg Lovenox if the renal function is normal, for prophylactic to every patient who's in the ICU or bed limited in the hospital. But these patients will require at least twice the dose and sometime higher than that. And I would probably continue that if there's no bleeding and, as such, obviously, I would probably continue that until their mobility improves. Vakash, you are muted. You're muted.
Okay, yes, Muni, you got your questions answered. Next, anyone else? I think someone was asking about the sedation, but he must be answered by this part also. And anyone else, if you have any question, you can unmute your mic and you can ask your question. If no question, you can ask your concerns which you are facing while dealing with the COVID ICU patients in Pakistan. Meanwhile, I think we answered a couple of questions on the Facebook. We'll wait for 5 more minutes and then we'll summarize our session.
Yeah. Because there's, I think, a couple of questions we did not answer on this chat forum. And
sure.
If Salah wants to take these questions,
Sure. Prospect of inhaled anticoagulation.
The other question, is there any contraindication of auscultating chest in COVID-19 ICU patient? Many seniors discourage this.
Sure. Yeah. So I don't know if there's any contraindication, but yeah, there's obviously a concern that, it can get contaminated, and, potentially spread infection. So at least in our hospital, and I think it's the case in most hospitals in US, you have, if someone is on precaution, you'll probably have disposable stethoscopes in the room, and we usually use that. And if you have to use your stethoscope, I just use my glove and put it on and listen to that patient. But if that's important, but I don't think so there's any contraindication. Correct me, Farooq, if I'm wrong, but yeah,
Yeah,
sometimes we have. Mhm.
yeah, I agree. There's no contraindication, but obviously there's the risk of exposure. So you want to limit your exposure as much as possible. And if auscultating the patient would not change management, I would not personally auscultate the patient.
Sure. And
Yeah.
then we're on team, I'm a fellow here, so we have like multiple physicians looking at the same patient. So we try to limit a number of physicians going in that room. So only one can go and listen. And then if nothing really is worrisome on ventilator and everything looks good, then if you want to skip that exposure, that's fine once in a while. But otherwise, there's no real contraindication as long as you're safely doing that.
Sure. So there's another question: if a patient goes into respiratory alkalosis despite non-invasive CPAP, what's next? So let's say this patient was in respiratory alkalosis because the patient was breathing at a rate of 40, 45, and you're trying CPAP, you're trying maybe even high flow in some situation where it's available for an hour or two, because this patient who's breathing at 40, 45, and their pH is, let's say, 759, 760, 755, that patient has a higher respiratory drive, right? The patient has, because this patient has hypoxemia, this patient is trying to get more air in, and then you're trying to fix the problem, which is hypoxemia or underlying problem that caused hypoxemia. So you gave non-invasive support to this patient. Let's say you started this patient on CPAP, and this patient has respiratory alkalosis. And I probably would not even follow this patient's pH. I would follow how this patient looks clinically when I start CPAP, and how the patient looks clinically in half an hour or 45 minutes after I start the CPAP. So once you start the CPAP, the patient is breathing at a rate of 40 to 45. Half an hour later, this patient is still breathing around 40 or even 35. That probably is not working. The respiratory alkalosis, the CPAP would not be sufficient to treat this patient hypoxemia. As long as you make sure the patient is getting 100% FiO2 from CPAP, that means this patient is heading towards intubation. And this will be the patient I will be very careful after I intubate the patient, because this patient, once the patient gets intubated, the patient is paralyzed if you use the paralytics. Now this patient cannot breathe above. You take away the respiratory drive, the patient cannot start the respiration. And if you set low tidal volume ventilation to begin with, this is the patient who will probably code or become severely hypotensive half an hour, 1 hour, 1.5 hours after being intubated. So this patient will need like monitoring and all other things that I already discussed.
Thank you very much. I think there is a question about the role of CPR. Very important question, because we know that when people are on ventilator, there's a high mortality anyway. Some studies were showing 70 to 80% because there's already cytokine syndrome set in. So what if the patient goes for, like, patient has a cardiac arrest? What are the guidelines? What is the advice to do? How many cycles of CPR, or should we follow the same ACLS protocol? Because we know that there's a great risk of aerosolization and contamination while doing that with minimal benefit. But I would take advice from Farooq and Tala on this. Tala, you first, please.
Yeah, sure. So yes, that's an important question, and I'm pretty sure most of the institutions have their own protocol to address that and some guidelines. Yeah, we really encourage having talk about code status. Someone who comes in with COVID pneumonia, it's very important to be clear on. But if someone is full code, so we should definitely have that discussion. If someone is on full code, then we in our hospital actually we just we always make sure that we are properly donned, so we have those N95 and everything, face shield, gloves and everything before we go in. Even if that delays, unfortunately, to go in, it's important, at least in our hospital, we make sure that we have all those precautions before we go in. And as far as duration and those things, there's no specified criteria here, but If someone, is already maxed out on FiO2 and high PEEP and they're hypotensive and requiring a lot of support, and at that point they code, and there's no acute thing which can be fixed, like Farooq was talking initially, if ET tube is displaced or those kind of things, any mucus plugging or any acute thing which you can fix, that's not present there. And it's just because patient's compliance is getting worse and worse, and despite proning and paralytics and everything, at this point they're coding. I would think there's really less hope that they'll come back. So in that scenario, I may do a shorter CPR or shorter code, as opposed to someone who's not maxed out on settings like for oxygen and PEEP, and you still have room to go up on things, or there are some acute things like ET tube displaced into one of the lungs, or there's a mucus plug as a pneumothorax, or things which you can fix. Then in that case, of course, I'll try my best and try to bring that patient back and try to fix that underlying thing which has caused them to code. But regardless, I would think that it's important to protect yourself first, and we really need to make sure that we have protective equipment before we go and start doing those things.
Thank you very much. Yes, Farooq, your take on this?
Yeah, I agree with Talha. And I would say that if patient has reached to the point of requiring CPR, despite doing everything, that patient probably has extremely poor prognosis. And there are some limitation during CPR on these patients. For example, with the ambu bag, if you use the ambu bag without the expiratory valve that generates aerosols, and there is a risk of aerosol generation and risk of infection in people who are standing next by and doing CPR and involved in the code. So those patients probably, if I would think about what is the chance of this patient coming back, and may do a brief CPR, see if that works. I probably would not do prolonged CPR on this patient who has extremely poor prognosis, and the other people can get infected as well. There's a question on any prospects of inhaled anticoagulation. So I'm not sure which inhaled anticoagulation, Usama, you meant tranexamic acid, which is one of the inhaled anticoagulants that is used in some of the patients who have bleeding from the lungs. And sometimes that can be used in some of the centers. It's off-label use for GI bleeding and trauma. The role for this is I would say there is no role. There is no proven study that it prevents DVT and VTEs, and it can lead to more problem. But even if it does not cause any side effect, the biggest side effect will be that the patient is not getting standard of care anticoagulation. So give this patient standard of care anticoagulation. Question on role of Flolan or epoprostenol. Flolan or epoprostenol is basically prostaglandin, and the objective is that you want to give it inhaled, right? You give it nebulized form in ARDS patient. There is no mortality benefit with this, but this can improve oxygenation. So let's say if you have done everything, higher PEEP, higher FiO2, low tidal volume ventilation, prone positioning, and then low restrictive fluid strategy, steroid, and still this patient is hypoxemic. This patient probably needs something more than that. And that patient, this is usually a last ditch resort before people think about ECMO, which is a big deal, for COVID patients. Many centers who have ECMO are not doing ECMO because of the risk of exposure. But you can use Flolan in that, at a fixed rate of 50 or 100, and then you want to dial it down once oxygenation improves and see if the patient still bleeds. So it is like just to buy more time until their ARDS improves.
Dr. Hassam has a question. I would request Hassam to turn his, okay, Hassam. So please ask the question and then they will answer.
Okay, so first of all, I would like to share one of my concerns. So we are using here like non-invasive ventilation, high flow nasal cannula and BiPAP at our hospital. But majority of the hospitals have the issue that in ICUs, we don't have the negative pressure systems. So that's a major concern, because if we are using non-invasive ventilation, so the risk of aerosolization is greater. We don't have the negative pressure systems in place. So one of my question was just that for the person who is intubating, is wearing a hazmat or a Tyvek suit necessary, or a surgical gown can suffice, provided that he is wearing the respirator or N95 mask, face shield, and everything else?
Very
Okay.
good questions,
And
Hassan.
one more question. And one more question. Do we have some protocol for preference of high flow nasal cannula over CPAP, or is it it depends on patient to patient? And because we never have used a high flow nasal cannula before. Thank you.
Sure. So, so high flow nasal cannula is actually one of probably the best non-invasive mode in patients who have hypoxemia, because it is tolerated pretty well, and it can provide up to 100% FiO2 and very high flow rate. So we usually go with the high flow first instead of CPAP in most of the patients who have acute respiratory failure with hypoxemia, just because it can provide a little bit pressure as well, 3 to 5. Unless the patient has, let's say, pulmonary edema, those patients will require a higher CPAP, or they have bad atelectasis, they will require a higher PEEP, a positive pressure. But otherwise, we usually go with the high flow first. But just remember, even with the high flow, I think the risk is again higher with the CPAP of aerosolization, and probably still less with the high flow. If you're doing high flow with I would start with a higher FiO2, 100%, probably a lower flow rate, probably 20 liters. That will reduce the risk of aerosolization. But if you're going above like 40, 50 liters per minute, then probably you're going into the risk of aerosolization. And that brings me to the first question that you asked: the risk of aerosolization. All these patients who are on a BiPAP, CPAP, who are on a high flow rate, high flow nasal cannula, or who are being intubated. So this, in order to answer that question, we have to understand this disease, how this is spread, right? So this is mainly a droplet transmitted disease. That means it usually is not aerosolized unless the patient is getting intubation or getting aerosolization procedure. In that case, if the aerosols are usually generated and they don't travel on long distances like TB for like many and many meters, but they probably travel at least 6 to 7 feet. And those patients, even if those patients are in negative pressure room, the aerosols are still out there for a couple of feet. So when you're doing those the intubation and stuff, the recommendation from the CDC and from WHO is that you use N95, but a tightly fitting N95. You know, if you have beard, or N95 is not suitable for your face size, for your face shape, or it's not tightly fitting, then it's not protecting you. And then you use a face shield, a tightly fitting N95 and a face shield, and you use a gown. That is a recommendation. And if you use it correctly, you do donning and doffing. Just remembering that when you did the intubation, you probably have some particles of virus on your gown, on your face shield. And if you're not using the face shield in front of your mask, you probably have some droplets on the outer part of your mask. Remembering that and doing correct donning and doffing, you will be saved just from doing these precautions. But if the patient is not in negative pressure room, then and then you're doing it and you don't have the face shield and you're using the whole surgical the suit, then you know it probably is safer. But again, you will have to keep in mind that the suit will all be contaminated from outside. So you have to deal it as a contaminated suit. You cannot walk out and then see next patient or touch that suit and touch something that you're gonna touch back. So just keep that in mind, because if you're using that suit and you're going out and sitting on your desk on your chair, that will get contaminated. I probably might use the gown and the face shield and the mask, and make sure that I'm doing correct doffing, because more than donning, doffing is important. Because when you're doffing, let's say you have some viral particle on the gown and you're removing it, it sticks onto your sleeve. And then you touch that sleeve, you touch your nose, you get transmitted from that side. So I probably will use, thing that I will make sure when I coming out of the room, I don't have a virus particle on my body.
Okay, we have I'm sorry, Farooq, I'm interrupting. People who have questions about donning, doffing, and PPE. So Farooq has a great had a great talk in our previous session that was named "From Room Air to Ventilator." It's available on YouTube, on Facebook. You just type "room air to ventilator" and you can listen that part in great detail.
Yeah,
And
and if you want to learn how to do donning and doffing, go to the CDC website. Just write donning and doffing CDC. It will show you all the videos of correct techniques of donning and doffing, and you will have to learn the techniques. You know, I think this is more important than learning mechanical ventilation, honestly, because you have to save yourself. And there is a risk of the people who get frequently exposed, they can have a higher intensity and severity of disease. So just make sure you learn the correct way of donning and doffing. Just go to the CDC website, watch those videos and practice those steps. Just remember those steps while doing it. Do it slowly, take your time, and make sure you do it correctly.
if you are dealing with the COVID patients and like in a ward, all are the COVID patient, then of course you can move from patient to patient because there's no risk of contaminating the other patient. They are already infected. But once you leave the ward and to see your office or to see the non-COVID patient, which I doubt because I heard that people have specific duties. They have specific weeks for COVID ward, which is good actually. This way you can save some PPE because Pakistan has some crisis and CDC has shared 3 strategies on PPE. There's a conventional strategy, there's a conservative strategy, and there's a crisis strategy. So in the third category called crisis strategy, they have mentioned what you can use. And even actually they have mentioned a white coat, a lab coat being used as a PPE cover. But again, the same rule applies. You cannot walk around with a white coat to your office or to the non-COVID patient because it's a mechanical barrier. And as Farooq said, the virus remains alive on a non-living surface, usually 48 to 72 hours. We had also shared about N95 and K95, how to use that. You should not discard them. Once you use for a day, you should put them in a black packet, like a black garbage bag, and leave it in the COVID ward. And then the same mask which you use on Monday, you can use on Friday. Okay, because Tuesday, Wednesday, Thursday, in 3 days, the virus on the surface would die. And then once you use the same mask for Friday, you can use it. And you do this 5 times. So one mask can be used 5 times according to CDC crisis management guideline. And after 5 times, they say that the fitting can be affected or something else. But 5 times this way you can use. So if you need 4 masks, you use this day schedule, you can actually spend 3 months, 2 to 3 months. So we shared all this data with so many medical pages because we came to know that people were discarding. After seeing every patient, you should not discard a K95 or N95 because it is reusable 5 times, but it should be 3 days apart so that the virus should have enough time to die. And then you can use it again. So, but again, I'm stressing everyone to see our previous session on the PPE, personal equipment, donning, doffing, everything we talked about. So I have here Talha Said. Talha Said has some question and concern related to ICU care. We all know that we do not have a critical care medicine training in Pakistan. We do not have a fellowship program in Pakistan. What that means, we do not have critical care and pulmonary medicine trained people in Pakistan. And this COVID crisis has actually exposed the need that this is a need of the hour. That I know when we were doing house job, being a medicine PG or medicine house officer, we used to manage a vent, but this could not be a replacement actually, because an internal medicine person dealing with the vent is a different thing versus a critical care attending or trained person, because it's a 3-year fellowship. Pulmonary critical care is a 3-year fellowship. So there's a great need in our country to start and to think about it, that this thing needs training. So Talha, you have any question? If you have still question, you can turn your mic on and video on. Talha Said. I think we lost him. Okay, Farhan Ahmed is with us. Farhan, do you have any comments and questions or anything to share? Farhan is ID fellow at Nebraska Creighton University.
Thank you, Okas, for allowing me to join. Just related to tocilizumab, yesterday we had a situation again, where there was a back and forth discussion between the ID teams and the critical care teams. we from the ID teams are more lenient toward criteria to administer tocilizumab to the patients, but I think critical care teams are still more cautious when they come up with these sort of medications. So I was just trying to figure out how, what guidelines or Pakistani, physicians or intensivists they are following when it comes to tocilizumab. Are they following the CDC, WHO, or any their local expert opinion? What exactly they're doing?
Yes, Farooq and Talha.
I'm not sure, Farhan, did you mean to ask audience in Pakistan, or did you mean to ask audience in US?
I think both. We will try to figure out how they are doing this thing, and I think it will need your expert opinion on this.
Yeah, here, and obviously I'm not expert on the tocilizumab, but tocilizumab is an anti-IL-5 antibody, and this is a very important question because many people are using it for like every COVID patient. So if you look at the tocilizumab trial, the trial that they used patients with a higher inflammatory markers and a higher IL-6. And just remember, if someone is higher inflammatory markers, they do not necessarily need to have an high IL-6. They may have high ESR, they may have high IL-8, they may have high IL-15. So
CRP also.
yeah. So you here what we use it for patients in number one. It usually for the most part is used as the late inflammatory stage when the viremia has resolved, like after the first 7 days. Although in some cases it can be used early as well, but you definitely want to check their IL-6 level, and if their IL-6 level is very high, those are the patients who may benefit, but there's no data if they're going to get any benefit in additional to steroids, because if you use steroids, it will not only suppress inflammation related to IL-6, it will suppress inflammation related to any interleukin, any inflammatory marker. Okay, so tocilizumab here in United States, at least at my institution, is being used on very limited patients, in patients who still have high IL-6 despite getting steroids and standard of care at late stage of the disease after the viremia, which is first 7 to 10 days. And I think in Pakistan, it is being taken as a magical, for the most part, what I have seen, and obviously people who are working in Pakistan will be able to shed more light on it. It is being used or considered by many people as a magical go-to drug, which it is not.
Actually, the studies which came from to support the tocilizumab were very small sample. They were from China. One study was 15 patients. One study was 21 patients. So 21N and 15N. That is very small, and they were all retrospective studies. So that is why the evidence is not very great. But again, as I said, this is like a rescue thing when you don't have anything else and you have some data to support, you just take a chance. The downside is that it is very expensive. And even in spite of this injection, some people may die. And when they die, the families, they always remember the last thing, which is the expensive injection, and they think of it as a poisonous injection. We have spoken a lot in our public awareness session for non-doctor layman people about what is tocilizumab, what is the data, and why people think that it is poisonous injection, when it is not actually. But the data is not very supportive. 21 patients, 15 patients, and they are all from retrospective. We have a question here about the thick secretions in these ventilated patients, because that's a very practical question that what should we do, medicine people, journal people taking care of ventilated patient, what should they do to make them like thinner or not to plug the circuit?
Okay, so before we answer this question, we'll take this as a last question because I think some of our speakers will have to go. And Talha, if you want to answer this question, I can defer it to you.
Sure. Yeah. So yes, secretions can be a problem, but with my personal experience, a lot of those patients actually have dry cough and not a whole lot of secretion, but and in our institution, they are running a trial where they're using, like, I think Dornase alpha, which thims your secretions, and then sometimes they use mucomist as well, but those are not proven, and we're just using them as part of research trials here. Other than that, I would just think, good respiratory therapist care, good frequent sectioning. There's sometimes closed system with, suction ports attached to ET tube, which can be used. But other than that, I don't really see, other than good frequent sectioning or maybe chest compressions to help those secretions to come out. If there is any magic thing which you can do. I mean, we can do things to dry out secretion, but really we do that as a part of palliative care. We don't really recommend that. That makes it more difficult to bring those secretions out actually.
Yeah, I agree. I would make sure this patient does not have a ventilator-associated pneumonia. So just do cultures of the thick secretions, and then regular nebulization, saline nabs, albuterol nabs can help. But I probably would, and frequent suctioning is the key. I probably would not use nebulizer in non-ventilated patients because that will increase your risk of aerosolization. But in ventilated patients, it can be used. But again, I think these patients, if these patients have been intubated for weeks, for days, you want to make sure this patient does not have tracheitis or ventilator-associated pneumonia. Look at the chest X-ray, see if there's any new consolidation. Then start the patient an antibiotic, do cultures of the secretions.
Thank you very much. And this concludes our session for today. We are 5 minutes over our time, but I'm grateful to Farooq Abbas, who took time and came, and he actually led this talk. He assigned all the topics and helped our other colleagues to coordinate. I'm thankful to Tala Nawaz, who took time and then came here, and I'm very thankful to Aftab Ahmed, who was actually working today, but he managed to take some time off. So this is a talk. Basically, this talk will be available on YouTube, on the Facebook links. It will be available on like as an edited version as well as the raw version. This was just to help our colleagues in Pakistan to understand the basics of ventilator and what they can do. I know we cannot cover everything in 2 hours. It's a 2-year fellowship, 2 to 3 year fellowship. It is not easy to manage in 2 hours, but these are the highlights. Like if everything is available on YouTube, videos, literature, we are always available. If you have any question about your COVID care in ICUs, our colleagues are all available. We are working to make a format to do EICU. Me and Farooq and a few others we are working on this, and soon we will be like sharing our WhatsApp numbers and in a way that one fellow in America should cover one hospital in Pakistan. Like one should be dedicated to Mayo Hospital, one for Allied Hospital. It's not like you guys don't know. You guys know better than us. It's just to share our experiences, because there's more advanced critical care in America there, and still America has the most number of COVID cases in the world. So we just want to share our own experiences, our mistakes, our learning points with you guys, so that you should make use of them if you can save any single life. I know it's a crisis situation for Pakistan, who does not have a critical care specialty. This is a need of the hour. We do not have control on these things, but what we can do, we are trying to do, and we will keep on doing that. We have done a lot of awareness sessions in Urdu language for public awareness. We have done, this is our 3rd doctor's awareness session in English language. And we are going to do one more session about the therapeutics, but we have covered a therapeutics part in our previous session from room air to ventilator. But we will be talking more about therapeutics. Someone asked a question about lopinavir, ritonavir, and interferon. There is no evidence. The lopinavir and ritonavir combination did not prove to be any of benefit. So there is no evidence for this combination. The triple thing is still under testing in Japan, and it is still, we are waiting on a lot of results. So all these trials we are waiting, but do what you can do a lot of proning. You have to figure out a way to do at least 12 to 15 hours of proning in the ventilated patient. Even in the non-ventilated patient, like a moderate pneumonia patient, proning has shown benefit. It improves the circulation to the posterior parts of the lungs and the preferential oxygenation, thus decreasing the physiological shunting. And this is something you can do without spending a lot of money, just like some manpower. But make sure you do not displace the ET tubes, and play around those numbers which Farooq, Tala, and Aftab talked about. all those three numbers, and you have to target your driving pressures, your petrol pressures, and your PEEP according to those numbers. And then make sure that you put all these patients on good GI prophylaxis, because there's a great chance of stress ulcers in these patients when they're intubated for more than 2 days. Do not do unnecessary CPR. I know I have talked to my colleagues in Pakistan. They told that families have created a lot of trouble when you guys don't do CPR. They think you kill the patient deliberately. But again, they are laymen. They should not be the people driving your guidelines. So first make sure that you ensure your own safety, because there is very less benefit of these CPR, because already a cytokine syndrome is set in. Even they are revived, they go back to the cardiac arrest again. So these are the highlights of today's session. And with this, I'm concluding, and we'll come back in 2 to 3 weeks with one more session on therapeutics. Share these links with all your doctors, healthcare professionals, all the pages, and we are just trying to help our country. And this was a project of King Edward USMLE Forum, and all the presenters, they are the admins of King Edward USMLE Forum. Thank you very much. Take care.
Thank you.